Let's give a big hand to Dr. Arun Kumar Singh.
Thank you so much, sir. So I'm already feeling at home. Thanks to all seniors and Dr. Chauhan. He introduced me to personally and everybody here, and you all are very seniors. Thanks to all of you and Forum for having me here. Definitely thanks to Sir who accommodated this activity under their idea, this campaign, which is actually dedicated for diabetes CME, but then for academic purposes they allowed us to have a discussion on endocrine, more of endocrine issues. Today we are going to talk about pituitary adenoma. So as I was introduced by Dr. Chauhan, I think different clinicians from different specialties are sitting here, and I hope I'll be able to connect with all of you this topic. And in general, in whole, endocrine is not a closed loop. So endocrinology is having interaction with each and every system. So endocrine diseases, any endocrine diseases can manifest in form of different symptoms, and these patients do visit different specialties, starting from pediatrician, gynecologists, general physicians, neurosurgeons, ENT specialists. Any of you can be the first one actually to have the patient having any of different endocrine diseases. So this is the plan of discussion or background, classification and categorization of pituitary adenomas. I am very specific, pituitary adenomas. There are many different varieties of stellar masses. Radiological team helps us reaching to a diagnosis. This is all discussion after we have reached up to a diagnosis of pituitary adenoma, which could be micro or macroadenoma. And in the role of medical therapy, so I am restricting myself to the medical treatment. The surgery, radiation and medical treatment are the main treatments for pituitary tumors or adenomas. So medical therapy has a lot to do in these different kinds of adenomas. And a very brief discussion about peri and post-op, pre or post-op medical management. A large number of pituitary tumors do need to be treated by surgical intervention by neurosurgeons, but then there is not many aspects which need to be managed medically as well. So as you all know, very simple, the presentation of pituitary adenomas, as I said, either it's going to be hypersecretion syndrome, hypersecretion of one or at times, not very commonly, multiple of pituitary hormone, excess of hormones, or it could be hyposecretion. So you can have a patient with hypothyroidism, not peripheral but central, or the more common is adrenal insufficiency, or even it could be growth hormone deficiency. Actually, patients can present with a short stature to pediatrician, non-functioning adenoma causing growth hormone deficiency. It could be adrenal insufficiency, it could be hypothyroidism, it could be hypogonadism. So a young girl can present to a gynecologist with delayed puberty, or a boy can present to a pediatrician or general physician with delayed puberty or no development of secondary sexual characteristics. So presentation is so varied. It can involve any system and it can present to any of the specialists. Those tumors which are usually non-functional or they do not create disturbances in the pituitary hormones, they go unnoticed and grow large, and they present with pressure symptoms. So restriction of vision, feel, headache, the common symptoms. And then there is large subgroup of patients, incident adenomas. They again could be micro or macroadenomas found on imaging, which is done for different reasons. So if I mention about the hypersecretion syndromes, these are well-known hypersecretion syndromes, prolactinoma being the most common, Cushing's disease, acromegaly, TSHoma being the rarest, the other two also not very common, but we all get to see them once a while. I was talking about deficiencies. So pituitary large tumors. So deficiencies are going to be seen in macroadenomas, not microadenomas. So large tumor mass is going to compress the normal pituitary gland, and then patient can manifest with different growth hormone deficiencies, can present with short stature, delayed puberty, infertility, hypothyroidism, just a common symptom of hypothyroidism, but central one, adrenal insufficiency, and DI in large adenomas again. So all these hyposecretion syndromes are being usually in most of the time or exclusively, you can say, macroadenomas, large adenomas, not microadenomas. And though gonadotroph adenomas are functional, they secrete gonadotropins, but these gonadotropins are usually inactive and you don't get a syndrome of high levels of sex steroids. So they are usually classified as non-functional. So gonadotroph adenomas are clubbed together with the non-functional adenomas. So to start with the most common one, hypersecretion syndrome, prolactinoma. More common in women. This classification, less than 1 centimeter, more than 1 centimeter, is universal for all kinds of adenomas. More common in women. In women, they tend to be smaller in size because they are diagnosed timely, because women present with menstrual irregularities, galactorrhea, infertility. So they are investigated timely and they get picked up early. But in men, they are generally not picked up early and they tend to grow, and they are usually diagnosed when they are larger in size. So macroadenoma in size. And again in menopausal women. So in premenopause you will have menstrual irregularities, but after menopause again it's going to be missed and they tend to present as large. Management. So this is the actually only kind of pituitary adenoma where the medical treatment takes higher place than surgery. Most of other tumors are going to require surgery as a primary mode of treatment. Prolactinomas are the exception, which can most of the time manage with the medical treatment. There are many objectives of the treatment. Restoration of normal gonadal function, because prolactin has a negative impact on the gonadal axis, leads to menstrual irregularities, luteal phase defect, hypogonadism, infertility, all those. So the objective is to restore the prolactin levels, to restore the normal gonadal function, and here we are talking about pituitary adenoma. So not only the normalization of prolactin, but also reduction in the tumor size and recovery from the neurological symptoms or pressure symptoms. These are also goals of the treatment. Most of prolactinomas are managed with medical therapy, with surgery and radiotherapy reserved for refractory cases. I'll be discussing about indications of surgery. But then before we jump to a treatment of prolactinoma, so there are so many causes of hyperprolactinemia. So we need to keep all these things in mind before we actually order MRI pituitary gland, because there are people who will have incident tumors or non-functional small pituitary adenomas, and coupled with the high prolactin levels, you might label them as prolactinoma, but actually they are not. So we need to consider all these factors as a cause of high prolactin levels: physiological, breastfeeding, stress, exercise, nipple stimulation, chest wall injury, a lot of medicines. The list is very long. So I can't nobody can remember all these medicines. The only thing, simplest way is to find out which medicine the patient is taking, and then try to find out if that medicine has anything to do with the prolactin levels. Nobody can remember all this long list, but as a common thing, so antipsychotics, antidepressants, and prokinetics as a class of agents, they are well known to cause high prolactin levels. So this is list of 2 slides. And then again there are challenges, the overlapping prolactin levels. So these are different conditions and prolactin levels on the y-axis. So macroadenomas have a relatively very high prolactin levels. You will not misdiagnose them as most of the time as drug induced, and other physiological conditions will have relatively lower prolactin levels. But then there is overlap between microadenoma, other cellular masses, or pregnancy, or renal failure, and drug induced. So history is very important. Once the diagnosis is confirmed, the medical treatment is usually the treatment of choice. We have two options. These are dopamine agonists, cabergoline and bromocriptine. Bromocriptine was used in the past, now more preferred as the cabergoline because of superior efficacy, better tolerability. So doses to start with once or twice a week, 0.25 mg or 0.5 mg, and bromocriptine is administered in higher dose and that has to be taken daily. The efficacy is relatively better with the cabergoline. This is number of patients over the weeks. The normalization of prolactin over the weeks with the cabergoline compared to the bromocriptine, and both have quick onset of action. Within few weeks you get the prolactin levels towards the normal range. Efficacy is better with the cabergoline. This is the result from one of the studies where percentage of patients who achieved ovulatory cycles or achieved pregnancy. So you can see the number is better with the again cabergoline compared to the bromocriptine. And on the other side is the tolerance or the percentage of patients discontinuing treatment because of adverse events. So treatment discontinuation is more with the bromocriptine, so the tolerance is better with the cabergoline. So it's not only the normalization of prolactin which we are looking for reduction in tumor size as well. This is just one of the patients. You see the starting tumor size and after a few weeks with the cabergoline treatment. A significant reduction in tumor size, that is also goal of treatment, medical treatment. And coming to the indications for surgery in the prolactinoma. So the ones who present with threat to the vision, that becomes indication. Tumor size increasing despite optimal medical treatment. Simple logic. So the patient is not responding to the medical treatment, or she is not responding to the, she is not tolerating to the high dose or the effective dose of treatment. So medical treatment is failing, or there is a contraindication to the medical treatment, or patient is not responding. In broad three categories. And threat to the vision, immediate threat to the vision. So debulking with the surgery is a choice in those situations. Radiotherapy is the least preferred option when the medical treatment is not working or contraindicated or not tolerated and patient is not fit for surgery as well. In those cases, radiation therapy can be considered. So after you have achieved the serum prolactin levels, what is the end point? Can it be discontinued? There are certain patients when you can consider discontinuation of treatment. Serum prolactins have been normal for more than 2 years and adenoma should not be visual for 2 years. So that is the criteria for both microadenomas and macroadenomas. But the very large ones, like those with baseline size more than 2 centimeters, you may not be able to withdraw therapy completely anytime. These patients will need much longer treatment. So if the tumor size is more than 2 centimeters, even if the prolactin is normal, but there is visible tumor, you should not discontinue. Try to maintain lowest effective dose. And they should not be discontinued even in menopause when there is a visible tumor. So yes, hyperprolactinemia becomes asymptomatic in postmenopausal age of prolactin. So we try to maintain it with the normal prolactin level with the lowest effective dose. Moving ahead to the other common, not so common, hypersecretion syndromes, acromegaly. The goals is again the control of hypersecretion and reduction in tumor size, relief from pressure symptoms and neurological symptoms. But here the primary treatment is definitely surgery. This is patient with acromegaly, this is algorithm. So primary treatment is actually transcranial surgery. For patients who are not fit for surgery, not a surgical candidate, high risk due to medical comorbidities, or tumor is largely unresectable, or where patient is denying. So there is a role of medical treatment. And again, those patients who have undergone surgery, but the tumor was not completely removed, this is the usual situation, not uncommon in acromegaly because tumors are very large. It's not always possible to remove all the tumor. They have residual disease most of the time. So after debulking with the surgery, they need adjuvant medical treatment to keep their growth hormone levels under control for metabolic correction of metabolic abnormalities, and also to reduce the risk of tumor growth. If they are not offered medical treatment, most of these tumors will regrow in size and they will need repeat surgery. So, not a primary treatment after surgery, and those who are not fit for surgery, there is a role of medical treatment for acromegaly. There are different treatment options: surgery, radiotherapy, somatostatin analogs like octreotide and lanreotide, cabergoline, and peglisoman is nothing but IGF-1 receptor antagonist. So, GH receptor antagonist. So there is excess of GH, but it blocks the effects of GH on peripheral tissues. It does not have any effect on the tumor. And there are different outcomes studied. The normalization of IGF-1. So the effect of GH on peripheral tissues is mediated by IGF-1. If you bring down IGF-1, the metabolic abnormalities will be corrected. These are the success rate. Of course, the most effective is the surgery. And even GH receptor antagonist has good efficacy in terms of lowering of IGF-1 levels, but then there is a risk of tumor regrowth. We all know endocrine loops, there is a negative feedback. So GH has a negative effect on the GH secreting cells in the pituitary gland, and if the GH is low, then the negative feedback is removed and the tumor regrows actually. So here IGF-1 has a negative effect on the GH secreting cells. Once you bring down the IGF-1, the negative effect on GH secreting is removed and it grows actually. There is a hypertrophy. So that is the risk here. And in terms of reduction in tumor size, I think surgery is the most effective way of treating acromegaly. So here is again a case of acromegaly with significant tumor reduction over the time. And this is with the octreotide medical treatment. Cushing disease. So Cushing syndrome is hypercortisolemia of any cause, and Cushing disease is a hypercortisolemia which is due to ACTH secreting tumor of pituitary gland. So again here medical treatment is not a primary choice of treatment for Cushing disease. Again, if you can localize the tumor, surgery remains the definitive treatment. But there are certain situations when patients are treated medically. One is preparing patients for surgery to control hypercortisolemia, and just like acromegaly, if there is persistent or recurrent disease after surgery is done, and those patients who are not fit for surgery, very simple. And after surgery, if some patient is subjected to radiotherapy for residual disease, radiotherapy takes time to have onset of effect. Meanwhile, you can try to control hypercortisolemia with the medical treatment. But unfortunately, we don't have many effective options for treatment of Cushing disease in terms of medical treatment. Surgery has definitely very good results. This is for the adults. Transcranial surgery, initial cure you can see close to 90%. So that is a preferred treatment. For those who have failed surgery or recurrence of the disease, for residual tumors, repeat surgery or radiation therapy can be option. For inoperable tumors, adrenalectomy is again one of the options for Cushing disease. And for milder disease, milder hypercortisolism, corticotropic-directed medical treatment for Cushing disease can be considered in the form of Pituitary or cabergoline. Cabergoline is not very effective, and even Pituitary actually gives control of hypercortisolemia only in 1/3 of patients. Not very effective. 60–70% of times you will not be able to achieve the remission. Treatment options. So there are different molecules targeting different steps in the hypercortisolemia. We are here discussing about pituitary disease. So Pituitary, and this is the somatostatin analog actually. Cabergoline, they are the ones which target the pituitary gland. You can use peripherally acting molecules which just help in controlling the symptoms of hypercortisolemia or Cushing disease. and there are adrenal enzyme inhibitors, not very popular and not widely used actually. The last hypersecreting syndrome is TSHoma. Not very common. It is one of the actually least common hypersecreting syndromes. Almost just 1% of functional pituitary tumors, not more than 1 to 2%. Again, surgery is the mainstay of therapy, and most of these tumors again present as macroadenomas. So, but before surgery, these patients are hyperthyroid. So, hyperthyroidism, uncontrolled hyperthyroidism is very risk, high risk for any surgery actually. So, same here. So, before surgery, they need to be made euthyroid, and treatment for making them euthyroid is not the antithyroids. So, do not use any kind of antithyroids when patient has central hyperthyroidism. What is the risk? Once you bring down the T3, T4 level to normal, the negative effect of T3, T4 on the TSS secreting cells is removed, and these are the TSS secreting cells, adenoma of TSS secreting cells, they will regrow. So you will make them euthyroid, but the tumor will grow bigger in size. So the treatment of choice for making them euthyroid is against somatostatin analogs. So the role of medical treatment is controlling hyperthyroidism before surgery. Sometimes it also helps in making tumors smaller in size, that is called medical debulking, and makes the job easier for the surgeon. And again, of course, if the surgeon was not able to remove the entire tumor, there is a residual disease, they can be managed with medical treatment. In selected cases, when surgery has failed, you can consider thyroidectomy also when not fit for repeat pituitary surgery. So these four were purely hypersecreting syndromes, and the next one is, it is hypersecreting, it secretes gonadotropins, but then these gonadotropins are actually biologically inactive. You will find high levels of gonadotropins, but not high level of sex steroids, neither they present with precocious puberty. So they are clubbed together with the non-functional pituitary tumors because they present with a large mass with pressure symptoms, and at times hyposecretion of other hormones like central hypothyroidism or adrenal insufficiency or growth hormone deficiency because of compression of normal pituitary gland by large tumor. So they are mostly macroadenomas because they don't get a peak, they don't have any symptoms of hormone excess or deficiency unless they grow large, and no clinical syndrome of hormone excess, and pressure symptoms or hormone deficiency are the most common presentation. No medical treatment for them because they are not hypersecreting. Replacement of hormone deficiencies is one part of medical treatment because they compress the normal tissue, and the primary treatment is of course surgery if they are big and compressing the optic chiasma and causing loss of vision field. The goals of treatment are relief of visual impairment, other neurological symptoms, removal of as much tumor as possible, and you also expect at times after removal of tumor or debulking, the compression or mass effect on the normal gland is removed, and there could be normalization or restoration of hormone deficiencies. That is also expected at times. So approach to pituitary incident trauma, it's not very uncommon. So for different reasons, the brain imaging is being done today's times. So you will not pick microadenomas most of the time in MRI, but you will pick macroadenomas, more than 10 mm. For macroadenomas, a thorough clinical history examination and biochemical evaluation is warranted to make sure there is no hormone deficiency, to make sure there is no hormone excess, and changes in the vision. So macroadenomas touching the optic chiasma, we must order vision field. If there is a vision field defect, if there is hypersecretion, hormonal abnormalities or vision abnormalities, they warrant treatment, and again treatment of choice will depend on the hormone. So for example, if it is prolactinoma, the medical treatment will be treatment of choice. If it turns out to be acromegaly, Cushing syndrome, then the surgical treatment will be the treatment of choice. no hormonal imbalances, no threat to the vision, even macroadenomas can be observed over time. So no need to rush for surgery. That was first part of presentation, the medical treatment of hypersecreting tumors and non-functional tumors. Just few slides on pre and post-op care, because most of pituitary, especially macroadenomas, do need surgery, and there are few points which you need to keep in mind when patients are planned for surgery and when surgery is done. So in the initial assessment, that is of course the taken care by a surgeon, having a detailed study by neuroimaging about the size, location, extent of tumor, so that they can plan their surgery accordingly. And the size of tumor has also impact on the other status of hormone secretion. So just like I said, macroadenomas are most likely to compress the normal pituitary gland, and they are the ones which are going to result in hormone deficiencies in post-op state, because surgery is going to be extensive in that situation. So if it was incident trauma, it was not the other way around, patient presented with some hormone deficiency, excess. If it was incident trauma, then we need to start with the beginning, thorough history, clinical examination, try to find out, as shown in the previous slide, whether it's a hypersecreting tumor or there's a hormone deficiency. And there are different challenges for different hypersecretion syndromes. For example, patients with Cushing's syndrome have high risk of thrombosis. So especially it's recommended that they should be put on anticoagulants perioperatively, not for all patients who undergo pituitary surgery. And especially again with the TSS secreting adenoma. So these patients are hyperthyroid. You must control hyperthyroidism before subjecting them to for pituitary surgery. So all clinical history examination for pressure symptoms, hormone deficiencies or hormone excess. So deficiency is also important. I talked about Cushing syndrome, they need anticoagulation. I talked about TSS secreting tumors, they need control of hyperthyroidism. Similarly, deficiency is also important. You all know the adrenal insufficiency can be life-threatening if not treated. And many times patients have adrenal insufficiency, but they are in compensated phase. If you don't work up for that, they will land up into adrenal crisis. So testing for hypersecretion, hyposecretion is very important for incidentally found macroadenomas and when they are planned for surgery. Vision field assessment is indicated only when it's macroadenoma and it is touching optic chiasma. When it is clearly seen away for optic chiasma, of course you don't need to do any vision field or any kind of assessment. It's not indicated for microadenomas. Preparation for surgery. So I was mentioning about hormone hyposecretion. So that also needs to be managed, not just hypersecretion. For example, both adrenal insufficiency and thyroid hormone insufficiency, hypothyroidism, both make the patient high risk for surgery. So you evaluate for all these hormone deficiencies, and these patients should be replaced with the deficient hormones before going for surgery. And the other hormones like growth hormone or gonadal steroids, they can be initiated post-surgery. No hurry to start steroids, gonadal steroids or growth hormone before surgery. And if patient has both adrenal insufficiency and hypothyroidism, never start thyroxine before adrenal insufficiency, because the thyroxine increases the catabolism of cortisol. So that can in fact make the patient land up into adrenal crisis. So always start with the steroids first, glucocorticoids, and then thyroxine, or maybe both together, but never thyroxine before glucocorticoid. And for the same reason, in severe hypothyroid, it was old practice to start some steroids with the thyroxine replacement when patients have severe hypothyroidism, just to avoid adrenal insufficiency. And in patients who have insufficiency, adrenal insufficiency, they need to be put on steroid replacement. And again, post-operatively, they need to be reassessed. Once surgery is done, as I said, this is discussion for non-functional pituitary macroadenoma. So there is a hyposecretion because of pressure effect of tumor. So these patients need to be assessed for recovery of function of deficient hormones. So in post-operative period, they need to be assessed on day 2 or day 3 when they are stable for recovery of adrenal axis, that is assessed with the morning cortisol levels. A simple test to do. When it's more than 16, is considered normal. And in other situations, it can be also assessed with the ACTH stimulation, the popular one, ACTH stimulation test. But in ACTH stimulation test, many patients may pass the test if the onset of disease is recent, not very long. So it basically tests the adrenal reserve. Only when adrenals are atrophied in long-standing disease, then patients are going to fail. If it is a recent disease of ACTH deficiency, adrenals have a good reserve, and if you stimulate them with the ACTH, these patients will pass. So morning cortisol is the one way and ACTH stimulation is the other way. So different algorithms basically recommended for patients with different values of cortisol. So less than 3, definitely you need to put on steroid replacement, higher doses, more than 3 to 9. They also need to be put on steroids, and then you gradually taper down and reassess periodically, basically. And those who have more than 16, no replacement. Again, endocrine evaluation in post-operative period, the intention is to assess the recovery of deficient hormones and also to assess the onset of new deficiency because of surgical insult actually. So few patients will have recovery because of removal of mass effect, and few patients unfortunately will land up into deficient state because of surgical injury or insult. So 10 to 20% of patients with pre-operative deficiency may express some recovery, and almost similar number of patients will develop a deficiency of new hormones. ACTH stimulation test is one of the popular tests to assess adrenal reserve. It can be done immediately post-surgery. The thyroxine has a long half-life, so thyroxine thyroid axis needs to be assessed after a few weeks of surgery. And for patients who were on pre-operative replacement for central hypothyroidism, you may consider tapering down the doses of thyroxine. Don't discontinue all of a sudden. If patient was on a high dose, you lower down the dose and reassess after a few weeks to see if the patient has recovered. And for reproductive axis, that is never an emergency. You can wait for a few weeks to months and watch for normal menstrual cycles in premenopausal women. And in men, you can assess that with the testosterone levels and gonadotropins. Again, same continued assessment of reproductive axis in men. Symptom-wise and biochemically, you can assess with the testosterone levels. If it remains deficient after 3 to 4 months of surgery, unlikely to recover, testosterone replacement can be considered. Posterior pituitary, most of patients have transient require of desmopressin, so DI can develop post-surgery, and it is very common actually in patients with macroadenoma undergoing pituitary surgery. Many of patients do not have this before surgery. And I'll be discussing very briefly about DI and SIADH actually next few slides. This is targeted gland function status in patients non-pushing pituitary macroadenomas undergoing transsphenoidal surgery. So basically what was done, assessment of pre-op and post-op function of different axes, thyroid axis, gonadal axis, adrenal axis. Before surgery, you see 26% of patients were hypothyroid, and out of them 87% improved after debulking of tumor, and 13% unchanged, 1 of 8 unchanged, and there's new onset hypothyroidism as well. So there is possibility of new onset disease and recovery of the existing disease, so that's why we need to retest for all these deficiencies post-surgery. Just few slides on water and electrolyte imbalances post-surgery. These are the very common complications after pituitary surgery, apart from many surgical complications that is taken care by surgeons most of the time, but they do call us for hyponatremia and hypernatremia, the SIDH, and that is insipidus. Because of insult to the stalk, So mostly before surgery, you can see as the ABP is synthesized not in the posterior pituitary, but it is coming from the hypothalamus, transported normal function. But it's very common to have some insult at pituitary start during surgery, and then you get many times a triphasic response. So immediately post-operatively there is secretion arrest, or the posterior pituitary goes in a state of shock, and then you get a DI. And after some time there is a recovery because of degeneration. Dying neurons release excess of ABP, and you get a syndrome of SIDH. And then again, once they are dead, again there will be DI. So it's very variable. Actually, it's not predictable. What I want to convey here, we need to be watchful of this syndrome of DI and SIDH after pituitary surgery for at least 1 to 2 weeks. Triphasic response is again one thing to keep in mind. So don't think that DI has settled and just treat DI and send the patient. So overcorrection of DI itself can lead to SIDH, and many patients will land up into SIDH after a few days of DI. So not very common phenomena, but then we need to keep on and keep an eye on urine output, sodium, and looking for the symptoms of both hyponatremia and hypernatremia. This course can be variable. So post-operative polyuria, prolonged polyuria, biphasic response, triphasic response, early hyponatremia, isolated hyponatremia. So triphasic, biphasic is SIDH, the DI followed by SIDH, then again DI. Few patients will have isolated hyponatremia, no DI. So we just need to keep all those things in mind and watching the patient, monitoring the basically electrolytes post-operatively for the next 2 days. And the last part of presentation, once the surgery is done, the assessment of remission, follow-up, continued surveillance is very important for both, to make sure there is no regrowth of tumor and there is no re-secretion of excess of hormones. That is again why it is important to make the proper diagnosis before subjecting the patient for surgery. If you know the nature of tumor, if it was hyper-secreting, you can detect the recurrence just by measuring the hormone level which it was secreting. If you don't know, you have to do MRI again and again. So if it was GH secreting tumor, you just to measure the GH or IGF-1. When it is rising, you know tumor is regrowing. Or if it was prolactin, you can reassess the risk of regrowth of tumor by just measuring the prolactin. So though I have different slides for each of these tumors, hypersecreting syndrome, prolactinoma, but then it's almost similar criteria for all of these hypersecreting syndromes. The criteria to make, to diagnose or label it remission is no visible tumor on MRI, and the hormone which was previously being secreted in excess, that should be normal. So that is the criteria for remission. They do need more frequent monitoring in the immediate post-op period, maybe first monitoring 6 weeks to 12 weeks, then maybe 6 monthly if everything is normal. For a couple of times, then maybe next 3 years or 5 years yearly, and after that, if all is well, you can reduce the frequency of monitoring to alternate years or once in 3 years. But they all have chances of recurrence in future, and all these patients need to be under surveillance lifelong. Non-functional pituitary adenomas, there is no other way than MRI to find out if there is a tumor regrowth. It is easier for prolactinoma or GS secreting tumors, where you can just find out the recurrence by measuring serum prolactin levels or GH or IGF-1. The frequency of monitoring initially maybe 3 months, 6 months, 1 year, yearly, and then maybe every 2 years and every 5 years. Patients need to be also educated about the local pressure symptoms, so they can report early if the recurrence of tumor occurs. Acromegaly, again same criteria, but we have advantage with the hypersecreting tumors that we can monitor it with the biochemistry. Patient does not need to be subjected to MRI each and every time. Special disease. So I think that was all. Very nice.
Yeah. To please come here. Please come on the dais. Thank you for a very illuminating and insightful talk into pituitary tumors. And I'm sure we have specialists across the spectrum. We have a gynecologist, we have a surgeon, we have an eminent endocrinologist in Dr. S.K. Mathur sir, an eminent pulmonologist in Dr. Mangla sir, an eminent pediatrician in Dr. S.K. Sehgal sir, and a psychiatrist, where most of these patients who present with headache are diagnosed as somatized depression and end up getting treatment from there. And we have some eminent GPs who see more than 250 patients, like Dr. Jitendra Saxena, my batchmate. It's a dream for me. If I see 250 patients, that day I will quit practice. I assure you, the day my token count crosses 250, I will quit practice. And we have an eminent ENT surgeon in Dr. Alan Parashar. So these pituitary tumors can present across specialties. So it's a very, very important topic. And therefore I would request Shireen ma'am, Dr. Shireen ma'am, to ask a question concerning gynecologists, because some of these patients can present actually to a gynecologist.
So I have two questions. First, most of the patients who are detected hypothyroid with the raised TSH level, along with that simultaneously prolactin is always raised. Always not, it is most of the cases. And we don't need to give extra cabergoline for this prolactin lowering. Only thyroxine for few weeks this prolactin gets corrected. This is the question number one, and the second one is that at what level of prolactin we should suspect for prolactinoma?
So coming to the first question, मैंने वो slide hide कर दिया था
उसको on कर लीजिए sir.
to save time. I had hidden that slide. So you know low T4, high TSH, but with high TSH there is TRH coming from above. TRH has a positive effect on TSH, and TRH has a positive effect on the prolactin, lactoferrin. So it is very common to observe in many studies. You rightly mentioned it's very common observation. Not only hypothyroid, the PCOS also has its known cause of mild hyperprolactinemia. So very common, but then you just take the primary defect, the hypothyroidism, you will get corrected hyperprolactinemia. And the same way for women with ovulated dysfunction or luteal phase defect because of hyperprolactinemia or even infertility, or if I talk about men with the testosterone deficiency because of hyperprolactinemia, we don't need to start with the testosterone replacement. We just need the prolactin and the gonadal axis recovered. So same way here with the treatment of correction of hypothyroidism, the prolactin, excess of prolactin is taken care of, and no need to give cabergoline in those situations. And the second question, you are nanogram per ml of prolactin.
Up to 600 level of without that
yes.
scan was normal.
Yeah, you will get ma'am cases. So difficult to say with certainty. That is usual, but then it has not 100% negative predictive value or positive predictive value. The large tumors, but actually they are not prolactin secreting tumors. The other thing is you might miss actually non-prolactin secreting tumors with the Stark effect, which have below 200. But prolactin secreting tumors are supposed to most of the time more than 200, but microadenomas, with microadenomas you can have less than 200, also not well differentiated tumors, and you will get cases non-tumorous hyperprolactinemia more than 200. So always I think better if patient has symptoms, at least if it is not just incidental finding. In a symptomatic patient, better to get an MRI with symptoms of hyperprolactinemia.
Thank you.
Thank you, Dr. Shireen. Dr. S.K. Padarth has another question.
Dr. Shireen said that we missed on CT scan, there was no adenoma. So I think for pituitary adenoma or microadenoma, MRI, that also special image of Sela are ideally recommended, not CT or not even MRI brain also. You have to focus on Sela
It's just-
if you diagnose, if you want to diagnose microadenoma. And then my question is, I know one lady who presented with discharge from the nipples last year, and she was very concerned, so my MRI Sela was done, and she was diagnosed microadenoma. Cavernous was started by an endocrinologist, and she came just 15 days back. She from Calcutta, and there was no prolactin level was normal. She was concerned. Again, MRI Sela was done, and there was no microadenoma. So how she should proceed? There is no prolactin is normal, and on microadenoma, when is
this could be a prolactinoma, this could not be. So here comes the last slides, the criteria to discontinue treatments. If we have the first MRI and there is a clear-cut microadenoma,
yeah, it was there.
and she definitely had symptomatic hyperprolactinemia. So she is remission. The prolactin levels normalize very fast, but the tumor shrinkage is a little slower process. You don't expect disappearance within weeks, at least few months. And if there is that good response, that is good news for the lady. But then immediate discontinuation is not even recommended approach. The tapering down, maintaining the normal prolactin level with the least dose which is effective in maintaining prolactin levels, and the criteria is maintain prolactin for 2 years at least. You discontinue early, you will have recurrence. And even after prolonged treatment, there are chances of relapse and recurrence. Just like Graves' disease or hyperthyroidism, you achieve the euthyroid state in a month itself with the antithyroids, carbimazole or methimazole. But then you don't discontinue antithyroid after 2 months of therapy. You have to continue it for a year or 2 years, least effective dose, and then taper down and discontinue same year.
So follow up only by serum prolactin level.
Serum prolactin, yes.
Need of MRI Sela.
No need.
prolactin.
No need. Microprolactinomas generally don't grow.
Thank you. Thank you.
Symptoms to be observed.
Dr. Mathur sir has a question.
And no,
symptoms to be followed. She has a galactoria to start with. That is the first symptom. If that is improved, it means there is a clinical improvement. My question right now is one. Regarding the TSS secreting tumors, which causes thyrotoxicosis, and as you said, there is no role of antithyroid drug per se. Is there the role of radiotherapy, ablate the gland, so that before you come for surgery, ablate the gland with radioactive therapy, so thyrotoxic is controlled? What's your view?
So it will just have the same effect as antithyroid. The concern there is you are lowering down the T3, T4, which is probably helping us to controlling the tumor size. Controlling the tumor size. Once you bring down the T3, T4 before taking care of this thing, TSH secreting tumor, that will regrow and it may be a threat to the vision. So that is again not advised.
So we give beta blocker to control the
Beta blocker, yes.
only red effects, no role of any antithyroid, even
No,
the ablation therapy is not.
No.
In hypothyroidism, as ma'am says, the hyperprolactinemia is not very uncommon. We see very often, but that level is not very high. It is a marginally high level. Eat hypothyroidism, I just get control. That's all key. Anything else?
So this loss of negative feedback is a very
Thank you, sir. Dr. Mathur. Dr. Sushil has a question.
So, sir, two settings, one 30-year-old female, serum prolactin slightly on the higher side. MRI shows 1 to 2 mm prolactinoma. And other situation, as you said, in accidental finding. You said observation. How do we observe? How often do we do serum prolactin on maybe MRI to see the size, or maybe wait for symptoms? And what stage to decide to start medical treatment?
So if the prolactin level is below 200 or 100 and the person is not symptomatic even, probably even I may not go for MRI, but then few people will have different opinions, not just to miss anything. MRI is done. So 1 or 2 mm lesions are most likely incidental findings and very unlikely to grow in size. There have been studies of natural history of microprolactinomas. 90% of the time they are found not to grow in size over longer run. And this patient, 30 years, you are telling of just high, not very high prolactin levels, 1 to 2 mm, asymptomatic. You can monitor prolactin levels more frequently than MRI. That is easier way to go ahead. Prolactin is not going up, unlikely the tumor will increase, is increasing in size. Initially, maybe more frequently, once in 3 months, something like that, for a couple of times. Then you can do 6 months and yearly, I think, like that.
Thank you, Dr. Sushil. Dr. P.K. Mangla sir has a question.
In case of prolactinomas, if there is a field defect, would you like to try a drug therapy or straight away go to the surgery?
So both can be tried. So the prolactin, the medical treatment has a really good effect in reducing the tumor size also immediately. It will be a mutual decision. If it is already getting affected, it's not just the threat affected. I think surgery must be there in the consideration. But before patient is taken to duty, you must start treatment, medical treatment, awaiting the decision. Medical treatment with the surgery is an option.
No, at times, non-functioning pituitary tumors, if they are causing obstruction to the stalk,
Yes.
and the prolactin levels rise,
Right.
the dopamine is not coming, can they be confused as prolactin or how do you prove that
Agree.
only surgery is the answer?
Very, very valid and very difficult situation. So that is well-known stalk effect. We call it compression at the stalk level because of large tumor. But then there, usually prolactin levels are not very high. You expect them 50, 100, below 200. Very high prolactin levels, 400, 500, more than 200. More likely it is prolactinoma. But yes, if there is a confusion and it's a equivocal thing, even we are not sure whether it's prolactinoma or non-prolactinoma, then definitely surgery must be considered in that situation when there's threat to division.
In case of growth hormone secreting tumors, see you do this glucose 100 gram glucose test. What is the level of growth hormone at which you label it as growth hormone?
GS suppression. We call it GS suppression, dynamic test for different endocrine systems. So GS suppression test, that is what you are talking about. Yeah. So
what is the level which is considered diagnostic?
yeah. So we are taking some below 1. So earlier the assays were not that much sensitive. Earlier the levels were considered 4 or something. But the latest consensus, the GH done by radio immunoassays is considered 1 to be suppressed, more than 1 unsuppressed. And IGF-1 is always there to help us in different situations. High IGF suggests that it's a GH.
Thank you, Dr. Mangla sir, for that wonderful question. Dr. Alan Parashar has a question.
Sir, over here I have 2 comments and 1 question. I am the person, I think, in the hall who has attended maximum surgeries in the pituitary gland. Because we ENTs work as a cyber police, surgical police. We give access to the neurosurgeon. Actually, the removing pituitary tumor is neurosurgeon's domain. Transnasal, transseptal endoscopic surgeries, which are where we decide mutually, which are where the neurosurgeon is comfortable, we are able to give them the access. Now, a lot of time it was said that the tumor, residual tumor is the issue. Yes, I would just like to point out in defense of my neurosurgeon colleagues that there are difficulties of reaching there. I think you must remember the slide that we have to go right across the nose, reach the base of the skull, and there you are working at the posterior wall of sphenoid, and then you remove. Your vision is such that you are looking just at the center and maybe slightly to the left or right. And there are very difficult anatomical positions, like there is cavernous sinus, there is cavernous carotid arteries also, then optic chiasma, optic nerve, everything is around. Beyond that, the moment you start removing the tumor, you hit the arachnoid plexus, and all this leads to bleeding. And therefore the fields are obscured. In that difficult area, you cannot actually control the bleedings too much, and therefore it is wise to leave the tumor behind rather than attempt too much and cause sudden gush of blood from thing, and then the patient cannot be saved. So this is one in defense of those. Second, Dr. Sir pointed out that when thyroid secreting, the TSH secreting adenomas are there, thyrotoxicosis is our main issue. Beta blockers can be given easily, but we should not be giving anti-thyroid drugs in those cases. And basic issue in surgery is that anesthetists were not able to control the thyroid storm earlier. Now we have got very good agents with the anesthetists to control those things. So I think they are able to manage in the intraoperative and postoperative period. So therefore we can go ahead with the surgery even with the higher levels. The question I wanted to ask is when we have incidentomas, how often we subject them to MRIs repeatedly, or you are happy with the other hormonal markers only? And then how often? Yearly, 2 yearly, whichever.
So I'll go second first. The first point, the residual disease. By no means I wanted to convey that as the failure of surgeon or the fault of surgeon. So these are invasive and aggressive tumors, and you have rightly pointed out the complex anatomy, and you are already doing wonderful job. It's a considered intracranial tumor, and you are just removing through the nose, and patient is conscious and walking on the same day. It is being even done nowadays as daycare surgery, pituitary surgery. So wonderful job by surgeons, no doubt on that.
Let's give a big hand to Dr. Parag.
It's the nature of disease, difficult to remove, and it's very common. Acro, especially acromegaly, to have residual disease. That is accepted outcome actually, and you help us to manage it medically. Otherwise, with so much big tumor, it's impossible to control growth hormone with that large functioning tumor. So after debulking, at least they can be managed medically, or radiotherapy is the alternative. Regarding second hyperthyroid cases, yes, they can manage it, but then I think it's not wise unless it's very urgent to put the risk. Just for the first point you raised out, it's wise to leave the tumor rather than putting the patient at risk of dying. Same way here, if it's not very urgent is again vision threat, I think that's all. You can manage hyperthyroidism with medical treatment. So I think we should not rush. And third thing about non-functional pituitary adenomas who are not going for surgery, how often to monitor. So if the tumor is not touching the optic chiasma, it's a little far, so it could be just 1 centimeter, more than 2 centimeter, 3 centimeter. You can classify that. 3+ are more likely to touch the chiasma and cause a threat to the vision. They should be convinced for surgery, and they need more frequent monitoring. Those who are not touching chiasma, we need a second imaging within 3 months. Tumor is stable, you can again just gradually reduce the frequency of testing 6 months yearly. Here we don't have any biochemical marker actually to see the tumor size. They are non-secreting. Only thing is we want to look for new onset deficiency of any of the hormones. So that can be done based on the symptoms or yearly. And anatomically, we don't have any other thing apart from MRI. Initially, maybe for first 6 months, 3 monthly, then maybe 6 months intervals for a couple of times. And if it is stable, you can again gradually reduce the frequency of imaging to yearly for a couple of years, then maybe alternate years, once in 3 years and 5 years.
Thank you, Lalit, for asking that question, and Dr. Arun for answering that beautifully. We have a wonderful psychiatrist here, my very close friend, Dr. Manish Sarkar. I sent all my difficult physician cases which I am unable to diagnose to him, and he diagnoses them for me. And he says, Dr. Chauhan, don't worry, it is simply depression. And at times he is stumped. At times he is stumped, and therefore he wants to ask you a question.
Hi sir. In my clinical practice, I get to get a lot of patients who are never been primarily investigated, but patients of headache. So invariably, a lot of them turn out to be patients of anxiety disorder, depression or migraine. So I treat them, but I know a lot of people I see, so a lot of them might be having a primary pituitary tumor. It also causes headache. So what are the symptoms I should look for so that I know that the person is having pituitary tumor, so that I can refer it to you?
Do we have neurologist here?
we have Dr. Bhaskar Shukla, our close friend, Dr. Shubham Vatsal's closest friend. He has taken a leave today, sir.
Okay. So pathological headache.
Arun sir is also very close to it.
Probably pathological headache he is asking for. Maybe you can answer better than me. But if I limit myself to the pituitary tumor causing headache, so early morning headache is the one thing I think which is the most important here. And apart from that, I don't know anything. Hormone excess deficiencies and the vision defect, which of course you must be asking about the vision when patient. We all ask about vision in patient presents with the headache. And hormone excess deficiencies. I think that is the all we can do.
Sir, I have a second question. So you have already mentioned there are a lot of patients of antipsychotic drugs. They have hyperprolactinemia. That is one of the challenges which I face last 11-12 years. I've been seeing in my clinical practice. So they have been doing good. Patients of schizophrenia, psychosis, stabilized over a period of time. It is a challenge. But hyperprolactinemia, they have their issues. Young people, mainly females, so highly problematic for them. So invariably I don't have any other option, so I change the antipsychotic drug and refer to a person, concerned specialist, endocrinologist. Is there anything that we can do regarding this matter, sir, irrespective of, rather than changing the antipsychotic drugs, or anything in the first time before referring to you?
Really difficult situation. So there are a few list of medicines right now. I cannot recall them. Every time I have to go back, and maybe you know more than me about those medicines which cause them and which don't cause them. Once we know they cause the drugs which offending drugs, and if there is an option, the best way to diagnose is if there is an option, we can switch to a non-offending drug. And the prolactin normalizes, you know, it was drug induced, you can just leave it. If we are scared of even starting dopamine agonist, because I know that is going to have the effect on your outcomes of your medicines which are acting on the dopamine actually axis. See, the simplest way is to, if you can switch to a drug which does not cause, that is okay. Most of the time actually it is not possible, and then we are not left with any other option, get an MRI done and rule out it's not prolactinoma. There could be coexisting two things. And if it is not again prolactinoma, MRI imaging is normal. If it is symptomatic, I'll start treatment in collaboration with the treating psychiatrist, very slow, very cautiously, because that can aggravate the symptoms of psychosis. Difficult situation.
Thank you. Some brilliant questions by Dr. Manish. Can we give him a big hand? Whatever mess we create, they clear it. he is the housekeeping guy. Okay, we have a brilliant pediatrician here, my teacher in subsurgeon, Dr. S.K. Sehgal sir. He sees all pediatric cases, and I think the presentation, the symptomatology of all these pituitary tumors is different in pediatric age group. At times, when the child complains of headache, we say, "Oh, unit test aa raha hai na, Monday ko." You know. So, sir has a question.
An excellent deliberation, Dr. Arun. I have just one or two simple questions. One is, how often do you see pituitary tumors in children? And second is, how do they usually present in your practice, you know? Because I'd like to have an insight so that I can diagnose it early and send it to an endocrinologist.
So fortunately, they are not very common in pediatric age group. And if we talk about cellular masses, I think craniopharyngioma becomes more relevant in that age group. I have seen only a countable number of cases in pediatric age group. 1 3 or 4 year old girl with GS secreting tumor, of course, growing taller than peers. So mostly it's a benign entity, but then the growing taller could be a thing. Cushing syndrome, same thing. In children, I have not seen any Cushing syndrome caused by pituitary gland in children. It's more common adrenal etiology in children. But anyway, Cushing syndrome, obesity with short height, that could be a very unique constellation. Usually obese children grow taller. They are overnourished and they are taller on their centiles, but an obese child who is shorter it's most likely pathological or some syndrome, or endocrinopathy. It could be a GS deficiency, simply GS deficiency, then again overweight and obese and shorter, could be a Cushing syndrome. And apart from that, I think pathological headache, which you all know more than me actually, and headache with vision problems, or midline abnormalities. Midline abnormalities are found to be associated with actually pituitary gland hypoplasia or agenesis rather than tumors. You are asking me about tumors. Pituitary tumors, not very common, very rare as in pediatric age. But the craniopharyngioma is the one which is more likely to be there, and that again will present with either hypothyroidism, delayed puberty, hormone deficiency, not excess.
Thank you, Dr. Sehgal sir. My friend, my batchmate, Dr. Jitendra Saxena, my dream is to see more than 250 patients. He already has been doing that for 20 years. But he has a question.
Sir, my question as a general practitioner would be, I think part of the question was also asked by our psychiatrist, when should I first suspect a patient? When should I first suspect in my practice a patient coming that he could be a pituitary patient of a pituitary tumor? First symptom, when should I be alert? Now I should investigate him for pituitary.
So, not simple to answer, but then as I mentioned, I'm repeating the same thing. The three symptoms, hypersecretion, hyposecretion, and the mass effect. So, mass effect is a different thing. Here we are talking about the symptoms. I think we are talking, the psychiatrist trained. So, any patients with any of symptoms, I think thyroid dysfunction is very great masquerader, just like tuberculosis, sarcoidosis. Thyroid dysfunctions. Anybody with any symptoms, I think, deserves even constipation. The gastroenterologist friends keep on sending me the patients presenting them to diarrhea and weight loss comes out to be Graves' disease. Severe constipation comes out with the thyroid hypothyroidism. And especially mental disorders, I think they deserve a baseline thyroid function at least. That can be a simple diagnosis. And if it is central hypothyroidism, then of course you have to think of it.
Is X-ray as a first investigation okay?
So that is very unreliable thing, very unreliable.
Can I ask another question, sir?
And imaging is never the first investigation when you are suspecting of pituitary disease. There has to be hypersecretion, hyposecretion, unless until it is headache with bitemporal hemianopia or you see optic disc atrophy, then of course you have to go for MRI.
Long time back they used to look at the cella.
When MRI was not available, and then they must have been missing a lot of them, and then they did not see you at that time.
So another question that I want to ask is, because in my establishment we also run an infertility clinic, although I'm not directly associated with it. A simple hyperprolactinemia may not be the cause of infertility per se, until unless we see LH, FSH and estradiol and AMH hormones as well. So what would be the, like in pituitary tumors, when we are suspecting pituitary to be the cause of infertility, what would be the LH, FSH and the other anterior pituitary hormones like?
Yeah, so it's going to be amenorrhea, low estradiol, with the low LH or FSH. I think we have simple clinical tests for that. There's a progesterone withdrawal. So you just give a course of progestin. If it is the endometrium is primed with estrogen, you expect a withdrawal. The simple clinical test rather than, I think, biochemical test. And prolactin does contribute to the infertility or subfertility by causing, having a negative feedback on the gonadal axis, high prolactin levels. It doesn't need to be sky high. It doesn't need to be macro prolactinoma or microprolactinoma. Even the usual hyperprolactinemias, they are treated by gynecologists most of the time. If there's a difficulty in conceiving subfertility, because these two luteal phase defect. So normalization of prolactin removes the negative effect of the prolactin on the gonadal axis, and the cyclic or the cyclic secretion of gonadotropins is restored, and the chances of ovulation becomes much better.
Hormones also would be
AMH. Yeah, that of course tells about you about the follicular reserve. But in that could be a primary ovarian disease or endometrial disease. You cannot find out the level of defect based on the image. It's going to be paired estrogen, LH, and FSH.
Sir, another undergraduate question for you, sir. Before I submit you to the DM level questions, two examiners are waiting for you, sir. Believe me, there will be DM level questions. I do not guarantee you will pass. Sir, many of our patients are on metoprolol and propanedics. And one of my patients, about 32-year-old, when in the third trimester of pregnancy, she was given a combination of proton pump inhibitor and propanedic. And that continued for about 3 years. And she came to me with some headache, which I diagnosed as stress-induced headache. But I got her prolactin done because I knew that prolactin could cause headache. And I found her prolactin to be borderline. Then I asked for the drug history. She was not receiving any medication from Dr. Manish Sarkar, but she was receiving this great combination of Dr. Shubham Mars. And I thought of getting the prolactins done. They were borderline, 22, 23, 24, done on the second day of cycle, whatever you advise. What should I do? Should I stop her domperidone, proton pump inhibitor combination and repeat her prolactin levels after how many days? And many of our patients, actually this combination has become the new sorbitate of gastroenterology. Once a patient on proton pump inhibitor and prokinetic, always on proton pump inhibitor and prokinetic, always. So your advice on that?
So the question is basically about indications of treating maybe hyperprolactinemia of different degree. So if it is not symptomatic,
mild headache, mild to moderate headache.
So if there is no tumor, the hyperprolactinemia itself will not cause headache. Of course, maybe you were right in diagnosis, tension headache or whatever it was, there is no tumor. Prolactin is also borderline. Maybe here you can ignore if there is no subfertility, there is no disturbances of menstrual function, or if patient is a man, no hypogonadal symptoms, libido is preserved, everything well. You don't need to treat prolactin levels of borderline elevation in those situations. Changing is an option when patient is symptomatic. Of course, you must try to bring it down or maybe try something which has a local effect than systemic effect. That could be a choice.
I would require your attention for another 10 minutes. We now submit Dr. Arun Kumar Singh to sir, to Dr. Tulsi and Dr. Kala. And no disturbance, please. Sir, go ahead.
Thank you, Dr. Chauhan. I'd like to have you as chair.
Smile, sir.
So, those were some wonderful questions, just very simple questions, Dr. Arun Singh. So, it's a master gland CNE today, and the master is the chairperson today. Mayo Clinic, which got consecutive 7 awards for the best hospital in the world, said 1 in 5, 1, 2, 3, 4, 5, have a microadenoma in the pituitary, which was again confirmed by meta-analysis of their autopsy studies, and they said 22% of the people have microadenomas and less than 1%. The prognosis, Dr. Arun Singh, would depend on the hormonal activity of the adenoma. Most are inactive and do not cause any clinical, do not have any clinical significance, do not cause any morbidity except morbidity due to excessive investigations. What do you say, sir?
Absolutely, sir. So they are called incident tumors. If you send each and everybody, of course, you will find adenoma in the pituitary, maybe some cystic lesion in the kidney. This is not unique of problem of pituitary gland. You send all of these, all of us for ultrasound kidneys, you will find many cystic kidney diseases. you get an ultrasound of liver, you'll get some lesions in everybody's liver. So unwanted investigation, of course, that is not suggested or recommended by anybody. So doing MRI just to look if you have adenoma or not. If there is a symptom, if there is a presentation consistent with the syndrome, of course you need to go ahead and investigate it. Otherwise we are not on a project to find out who has pituitary adenoma or not.
Tulsi, can I add one thing? Thyroid incidentaloma is very high.
Yeah.
A lot of what have done. We did a study in March, we found incidentaloma is up to 10%.
So thyroid being victimized because it's a subcutaneous tissue and you can easily
so
find it out.
incidentaloma is found, but don't need to do any further investigation.
Most of
lot of people advised ultrasound cardiac accuracy, which was not required. So over investigation is not
so thyroid is the biggest example of over investigation.
That's what I said.
Not over investigation but over treated also.
Yeah. So to further my question to you, Dr. Arun Singh, pituitary apoplexy is very rare. So sudden severe headache with diplopia, rapid bleed in the pituitary is seen here. But let us discuss a few cases of the pituitary apoplexy which has been reported by the Journal of Endocrinology recently, and they said, see, after giving the Pfizer vaccine, see, at least few cases have been seen which cause this pituitary apoplexy. So the apoplexy occurs secondary to vascular dysfunction because of the overwhelming immunogenic response. So probably corticosteroids are here to be used to take care of this. So as we know, COVID-19 vaccines can cause thrombocytopenia, can cause bleeding disorders. Not only that, it can cause arterial and venous thrombosis. As one of our colleagues' wife had this, and this occurred within days to weeks. See, after the vaccine has been given, this seems to be because of exaggerated immune response. This is what the Journal of Endocrinology said. So, have you seen any such cases after the vaccine? The apoplexy, which is very rare.
It has been reported.
It has been very rare, so it's not just.
I refer to that.
So sir is mentioning of those reported cases. So I think not just apoplexy, so many syndromes being linked with the COVID itself, and nobody knows exactly the pathogenic mechanisms or anything. I have not seen
exaggerated immune response, sir. So you talked about Cushing's disease.
I have not seen apoplexy, no cases I have seen. I have seen more of new onset thyroid cases, hypothyroidism. Very commonly. And not very usual response in terms of hyperglycemia. So this was very peculiar observation this time. There are patients of different autoimmune disorders on steroids earlier, but then with the COVID, the hyperglycemia response was very different compared to steroid response.
So my last two questions, Dr. Arun Singh. Cushing's disease, Cushing's syndrome, what about Cushing's triad? So friends, we have a Cushing's triad also.
Yes, sir.
Can anybody say what is the Cushing's triad?
We have a person to answer.
Sir, please.
I came prepared.
Cushing, so Harvey Cushing was a great neurosurgeon. He was not an endocrinologist and he did a lot of great job in the field of endocrinology. So Cushing triad is intracranial hypertension, bradycardia.
So Cushing's triad was because of increased intracranial pressure, as Dr. Polar hinted.
Yeah.
And the three hallmarks were bradycardia, increased pulse pressure, and respiratory distress. So these were the Cushing's triad. Finally, Dr. Arun Singh, talking about the exogenous Cushing syndrome.
Sir, Dr. Tulsi sir, did he pass his DM sir or no? Sir, please. Sir, give him his DM sir.
Done, sir, done. He passed with flying colors. So, Dr. Arun Singh, my last question to you.
Dr. Arun Singh, कि सर आप DM हो गए, अब माफ कर दो.
Dr. Arun Singh, my last question would be regarding the exogenous Cushing syndrome. See, with oral corticosteroids, repeated injections, I have orthopedic friends to give. Arbuda, you know about that. And also about inhaled corticosteroids. It's really very rare you get, if you use massive repeated doses of inhaled corticosteroids that could cause probably an exogenous Cushing syndrome. So, just a word on that, why? Because the ACTH secreting tumor also lungs, pancreas, thyroid and thymus and adrenal adenomas as well, and familial Cushing syndrome also can cause these exogenous Cushing syndrome. Sir, a word on the exogenous Cushing syndrome. And how do you treat that? Probably you need to withdraw these drugs and they are fine. Thank you, sir.
Dr. Kalra, sir.
Sir,
Can we just have silence for next 2 minutes and give a big hand to Dr. Kalra for giving us words of wisdom. My elder brother and one of the most important academic pillars of the group.
Sir, my pleasure to be last. वो कहते हैं कई बार पहला डब्बा लास्ट में लगाना पड़ता है, तो मैं पहला डब्बा हूँ तो लास्ट में लग गया हूँ. फिर भी, sir.
But not the least, sir.
Not the least, sir. I was enjoying the questions as they came from my other friends, which were usually not given the chance. I am really feeling happy that they asked their questions. Yes. And there are some people who want to ask questions, they don't muster that courage to ask questions. They are hesitant. I was very hesitant earlier, sir. आज से 20 साल पहले
they don't get the time to ask because you ask so many questions.
सर कहते हैं छाछ तो बोले, छलनी भी बोले. सर, मैं थोड़ा सा याद करना चाहता हूँ सर. मेरे सवाल, if he was a DM examiner, I am internal. मैं आपके साथ हूँ. मैं तो ये कहना चाहता हूँ कि जब मैंने शेख मुख्तार को आज से 50 साल पहले देखा था, शेख मुख्तार, and Khali also some 20-30 years back, I doubted when I read about what is acromegaly and how the growth hormones affect the body. So I think they should have been suffering from. I am not sure whether they were or not. And about sir, as my most learned friend has said, that 20% have microadenoma. We all are having cancer cells. Every day we produce cancer cells, but our system is so robust. We clear them all. As long as we are clearing, we are happy. Sir, I rate prolactin as pro-BNP. Pro-BNP is increased in so many conditions. It's at a level, cut-off level. When we level it is CHF or whatever, and then it's a prognostic marker. So I hope I'm in the right track in thinking on that line, sir. And sir, about a few simple questions, sir. A child with gigantism or other overgrowth is suspected to be having a pituitary problem. What about the reverse of it? Stunted. If one is having stunted, can he have a pituitary adenoma suppressing the growth hormone? Yes. Your point.
So, growth hormone deficiency you are talking about for that child, stunted growth. But then there are so many causes of stunting,
thyroid and so on.
Growth hormone deficiency being the last. So that is our approach also. We see hemoglobin.
Should we doubt there?
We see renal function, we see thyroid function. There is simple ways to assess. And the tumor causing growth hormone deficiency, what I have seen and even I think in literature is these are not the pituitary tumors, the craniopharyngiomas or other cellular masses, or with the other intracranial tumors who have undergone surgery or radiation like medulloblastoma or something. So that is a clear-cut case, but somebody presenting with this stenting, I think craniopharyngioma is much more common than pituitary tumor.
My last question, sir. कई बार कहते थे impossibilities में बैल का दूध नहीं निकल सकता. So if prolactin is increased in male, can it produce milk?
Very rarely, sir. It can.
Because it's not impossible.
So there is gynecomastia. It's not impossible. It's not impossible.
Friend, I think all of you would agree today that we had a most wonderful session. We had